Hey there everyone, this is Dr. Hodges. I am super pumped. I just got my selfie stick and I had just done a video, and when I was switching hands it turned off. So this will be take two. I had a chance this week to go to our annual meeting for ASMBS, that's our Bariatric Metabolic Society, and I had a chance to go to some really good talks and discussions. Several of the portions of the conference that I went to, that they were debates. So it was common debates that we might have in bariatric surgery as to what procedure might be best for in certain instances. And what I've certainly found in medicine is that sometimes if you can have a lively debate, it's usually because we don't have enough long-term data to give us a definitive answer. And so sometimes you just have to take it on a case-by-case basis. And that's really what I try to do in my own practice. So what I kind of like to talk to you guys today about is reflux disease, what happens when you have it, and how can it be affected? Can it be resolved? Can it get worse? What are treatments? Such and such. So reflux disease can occur for a number of reasons. You can get symptoms of bloating, heartburn, that feeling of bile if you have bile reflux. If you have acid overproduction, you may get this if you have a little bug in your belly called H. pylori. That's a little bacteria that can cause symptoms of reflux and bloating. It's really prevalent in our population, and generally to eradicate it, you take 2 weeks of 2 antibiotics and an acid blocker. Some other reasons why you might have reflux disease, if you have a hiatal hernia, and what that is you have your breathing muscle and there's a natural opening that the esophagus goes through. And in some folks that opening is a lot larger, and when that happens, acid can more easily escape up into your esophagus. You know, you actually don't have a true sphincter or true pucker between your esophagus and stomach. The esophagus really uses a lot of gravity to help get, even though it will peristalse or move things down, it's not strong like your leg muscles. So they're actually, the muscles in your esophagus are fairly weak. And so your body did not want to have a large amount of pressure to overcome to get food from the esophagus into the stomach. And that's kind of one of the reasons why the junction between the esophagus and stomach is kind of loosey-goosey at best. And it's made up of a number of different parts. There's portions of the diaphragm, there's portions of the esophagus, and portions of the upper portion of the stomach that all kind of contribute to this mechanism for your lower esophageal sphincter that really plays a big role in whether or not you have reflux. If that sphincter is too loose, you can certainly have reflux, because that means that acid's or bile can flow up into your esophagus. And if you're overweight, I mean, certainly obesity is one of the #1 causes for reflux in America. Also, if you're pregnant, because of that increased intra-abdominal pressure of that little baby, push it up on everything. So it is not uncommon at all for me to have a patient that will come in with symptoms of reflux disease. Now, does this mean that you cannot have surgery? Absolutely not. In fact, some of our surgeries can even help reflux disease. On the other hand, we do have a couple of surgeries that may actually exacerbate those symptoms. And so that's really what we were kind of diving into today, is what are the best procedures when you have reflux disease? And you know, what we have found and what the literature has kind of borne out is, if you get a sleeve causes increased pressure in the stomach, which is fine. It also, whenever you're creating the sleeve, just by nature of how you create it, you kind of disrupt some of the muscular fibers in your stomach, and right near where the hiatus is, that makes up that lower esophageal sphincter. And that's why just a sleeve in and of itself can predispose people to developing reflux. Now, does that mean that everybody that gets a sleeve is going to get reflux? Absolutely not. I think the number is right around 30% or so. However, It is also not uncommon for patients, if they have a sleeve, I think the number was anywhere between 20 and 30%, that if you already have reflux, that many people can actually get an exacerbation of their reflux. So I know if you come to see me in clinic, as a general rule of thumb, if I know that you're being treated for reflux, especially if it's fairly significant, I'm usually going to guide patients away from a sleeve and tend to recommend more of a gastric bypass. Now that's just a general rule of thumb. I mean, you cannot use a hard and fast rule for everyone. I don't know if patients have certain family histories for pancreatic disease, for liver disease, if they have a family history for esophageal cancer. I mean, there's a number of different things that we have to look at whenever we're making these decisions for our patients. But from what I was seeing in our conference, what I'm finding is that a gastric bypass is going to be much more effective at helping you treat your gastroesophageal reflux disease as opposed to a sleeve gastrectomy. And in fact, they are trying to get away from saying that a sleeve can help with reflux disease. Now, what about our patients that come to us? They really don't have any dysfunction in their esophagus or stomach, and they didn't realize, or they didn't end up developing reflux until after they gained weight. Maybe they've only been overweight for a couple of years. Those people, by and large, more than likely, regardless of whatever surgery that they're going to choose, their reflux is probably going to resolve, because more than likely their reflux was really more of a function of their weight as opposed to some anatomic issue going on. Which is why it's key for your doctor and surgeon to really look at your medical history to see what is going to be the best procedure for you. Now, another thing that they talked about in our conference was, what do you do if you are a patient that has something that's called medically refractory reflux, meaning you're sleeping on a couple of pillows, you're propped up because you know if you lay down, you're going to be irping up a whole bunch of stuff. You're taking an acid blocker twice a day, probably also taking some stuff called Carafate. And that helps to kind of, it's like Tums on crack, and it really helps to coat your esophagus and stomach. If you're taking acid blockers, you're taking Carafate, your symptoms aren't going away for at least 3 to 6 months, and or you're really tired of taking these medications, then that is really when you become a candidate for surgical intervention. The main debate that we were having today was, what is going to be best for the patient? Is it better for a patient to undergo a gastric bypass if their BMI is over 35? Or is it better for the patient to undergo a Nissen fundoplication? So what that is that's where you wrap the upper portion of the stomach around itself. It was a really lively debate. It was great. They did speak about, there was a big consensus statement that was just issued, although they said that they still don't have good long-term data on this. But they said it is a reasonable recommendation for a patient to either undergo a gastric bypass or Nissen fundoplication if your BMI is over 35. But this is where I feel like the art of medicine comes into play. And also what I really liked about being in this room full of scholars and fantastic bariatric surgeons, I really liked their emphasis not on reflux. What I really liked was when they were debating which of these procedures is best, they weren't looking at what is best for this patient right now. What they were looking at is what is going to be good for this patient 5 years from now, 10 years from now, 15 years from now. And if you tell a patient, I can give you a surgery laparoscopically, it'll make your reflux go away, they're like, sweet. But what if you tell your patient, you also have high blood pressure and diabetes, maybe you have some sleep apnea, and I also have a procedure that can make those go into remission, and you'll probably lose 60, 70 pounds. What would you prefer? Oh, and the risk factors are the same. Recovery time is the same. What sounds good to you? I mean, I feel like if you present it to your patient that way, and you're also looking at your patient as a whole as opposed to just one single problem, I mean, 9 times out of 10, your patient is going to want weight loss surgery, because you're not doing the surgery just for weight loss. You're doing this surgery to help them with the multiple comorbidities. It was really good to see the presenters today really stress the importance of treating our patients as a whole and really trying to look at our long-term health of our patients. You know, if you have a BMI over 40, we have data now that shows that you will lose 10 to 20 years off your life. That's the same as someone that's been smoking a pack a day for like 20 years. You have the same life expectancy as a smoker if you're overweight. And I can tell you, I believe, I never smoked, but I know a lot of people that have. It may be a scotch easier to have surgery and lose weight than it is to actually quit smoking. So certainly my recommendation would be get one of these bariatric surgeries. We also debated, if you've already had a previous anti-reflux surgery, what is the best thing to do? And that was the recommendation, that you could either do a redo fundoplication or you could get a gastric bypass. None of these studies were ever looking at or even considering a sleeve gastrectomy, because a sleeve could certainly be more of a pro-reflux, not an anti-reflux type of procedure. So I hope that this has helped. Please know that when you go to see your surgeon, there's always going to be a plethora of questions and considerations that we need to look into. Having these surgeries is way more than just losing weight. And I think that we have to change our approach. I've said this time and time again. We have to change our approach to obesity. This is a disease process. We have to treat it as such. And if we're not treating all aspects, then our patients just aren't going to have a good long-term result. And I want my patients to live. I want them to have an amazing long life. So I hope that this has helped. Share this with your friends. Y'all take care.